Professor Pablo Cesar-Sanchez. Professor Pablo Cesar-Sanchez is an educator, physiotherapist, and specialized consultant in clinical reasoning, innovation, and technology. Professor Pablo is an assistant professor at the physiotherapy department in Universidad Europea at Madrid since 2006. Let's welcome Professor Pablo.
Hi, how you doing? Welcome everybody from around the world. It's a pleasure for me to be here with you, talking about what I used to do daily with my students. As you said, I'm a physical therapist, and nowadays I'm working in the Universidad Europea de Madrid. I'm working in the School of Sports and Physical Therapy. I have been here for 17 years, and I got my background is clinical reasoning, manual therapy, and innovation, educational innovation. Okay, I also have a PhD in on neuroscience in the field of the physical therapy. I did a work trying to discover exactly how physical therapists make decisions, and this is something that we are going to talk today. Okay, so probably the big questions that we used to have in our minds when we are patients is how our clinicians make decisions, how they look really clever, and with that is a small piece of information how they could get a diagnosis, for example. No? And this is something that we used to have on the TV shows. Yeah? In order to explain you that, probably some of you already know this. I'm going to use what we call the dual system of making decisions, because probably it's one of the best research and probably is one of the best well known around the world. And that mainly said that we have different parts of our brain, in order to make different decisions. The system one are the parts of the brain who use intuition and pattern recognition. That really quick system in order to get a decision. And then we got the system two. The system two is mainly localized in the prefrontal cortex of our brain. And it's what we used to think, in which we think in logical, slow, by wishful thinking, and we used to use that system one. Okay, so here what you have here in the screen is the information is coming from the left and it's traveling to the right. Okay, and we used to use all our senses, try to gather all the information as we could from our patient in order to have more chances to get a good result. Okay, so all the information that we are gathering are relying in one part of our brain, and that's called the amygdala. The amygdala is a pattern processor. If the information from the patient that is coming from the patient, we recognize it, we put that information immediately on the system two, on the intuitive and unconscious system. Okay, and we have several parts of our brain doing that. But on the other hand, if the information is not recognized and we don't have that information clear in our memory, we used to put that information on the system two. Okay, sometimes that information travels through both systems. Okay, it's like a little discussion about them, about both. Okay, and sometimes we get a conclusion, we get a decision using both systems. But sometimes when you talk this with their experts, they used to say they could identify only, okay, I was using the system one, or I was using the system two. Okay, so at the end, sometimes we get some calibration to read the diagnosis. The context, how much time do we have for treating this patient, for example? Okay, the evaluation of the task, our self-efficacy, and also absolutely the patient regarding his or her presentation, the patient and what we think about that patient is going to affect what we decide. Okay. What is exactly a cognitive bias? A cognitive bias is a little deviation about what we used to think, which is the typical and logical thinking, okay, when we are dealing with patients, okay? Sometimes it makes us better professionals, but usually it provokes to make us inaccurate thinking, for example, irrational interpretations, or we used to come up on solutions that probably are not the best for our patients. Okay, these biases are well reported in the literature, and we have a lot of research about that, not only to know exactly which are the main ones, but also how they affect. And nowadays we have enough information to to know how to deal with them, how to tackle them when those values are affecting me and my decisions. Okay, and this is what I will be talking about today. Okay, some of the most representative one, for example, this primitive close. When we close the information gathering and we think that we don't need enough information to know exactly what's going on with the patient, okay, and then we realize that probably if we gather more information, probably we will be able to to get a better solution. Okay, this is one of the main cognitive bias, and there is a lot of literature about this. Yeah, this is like a really big umbrella, a big bias umbrella, and there are also little different classifications of those bias in the literature, and all of them have its own remediation. Okay, anchoring bias. Anchoring bias means that that we used to embrace when people are committing this bias is because they are embracing the initial information, the initial data that that they are gathering, or they embrace the initial diagnosis. Like they think only with this initial fifth pieces of information they embrace to that. Okay, and they're not using the information that they are gathering later. Okay, sometimes we are right. We are using our clinical pattern recognition, and just only with this small initial information, we get the exact diagnosis. But when we are abusing about this bias, probably we are stopping. We are using. It is another way of this perimeter closure. It is another way to get wrong with the diagnosis because we need more information in order to get exactly what do we know. Okay. Representative bias is another one. Is when we spend a lot of time trying to find exactly in my patient the clinical pattern I have in my mind, or the clinical pattern that it's in the book, and until we are not pretty sure that we got the full photograph of this clinical pattern, we don't make a decision, and we are spending a lot of time, okay, with this patient. Okay, so once we have a quick idea about how we make decisions and which are the typical bias that some of them that we used to commit, let's put this in an educational clinical context. Okay, and let's see what the clinical cases offer to us in order to tackle this bias. Okay, there used to be over in the literature, you could find 3 specific ways in order to tackle this. Okay, the first school says like this model. No? You get more experience, you will get more knowledge, and there are some really good researchers working on this and showing us that usually when you get more experience, you get more knowledge. It's not necessary always in this way. Okay, but it used to happen. Okay, so absolutely, when your student asks you, okay, when are you going to do this better in the future? The answer is yes. Okay, then we have in the literature a lot of proofs of this. Okay, also with checklists. Nowadays, they have developed there are a lot of checklists coming from the research in order to try to be aware before making a decision, trying to be aware if you have been biased by yourself or by your thinking, your emotions, or whatever. Okay, so it's like the system 2 trying to overrule the system 1, because usually this cognitive bias relies on the intuitive part. Okay, so before making a decision, you have a checklist of questions. Ask yourself if you have this and this and this and this rule out. Okay, so and in order to do that, we are using a really interesting part of the clinical reasoning called metacognition, and this is really nice in order to train with your students, because they could also build their own checklist in order to help them to tackle this bias. But I want you to pay attention specifically in this last method, what we call cognitive deviation. And this is when psychology helps us a lot in order to try to change this behavior, because this is a behavior. Okay, when you got a bias, is because you will think that you should think in that way, or sometimes you don't know exactly what are you doing, and you need to, for example, to record yourself when we're doing simulation in order to know exactly what are you doing. Okay, so I'm going to show you which is the ladder and the steps that we used to use in the clinics and in the school in order to tackle this specific bias. And remember that we are trying to change the behavior of, in this case, of our students, of our junior physical therapists, in order to behave a different way. So then first steps are going to be really intuitive. Okay, we need to trigger the bias, and we need to make the bias aware not only to the student but also to the educator, to the physical therapist or doctor or nurse who is helping their students. And in order to do that, we have several methods, and here the software of both the internet help us a lot in order to do this. Okay, first of all, you could be recording or watching what the students are doing, if they are doing that individually or in group. But if they work in group, this method is awesome. It's going to help you a lot in order to help them. Okay, you could be paying attention there, making notes, recording. Okay, and you could always do this. Okay, but the software, the virtual software provides the students several ways in order to give you feedback. Okay, it could give you at the end immediately a quick feedback about what's going on. You could also use the diagnostic questions to get a better understanding about what the student thinks. Okay, but with the skills, with the knowledge, with the clinical reasoning, you could also use the tracking that the software is doing for you in order to provide you information about the skills that the student have been using or not, and also how was her performance during the different parts of the system. So here, this little reports could help you and could help the students to know exactly in which parts the student have been doing great, in which parts doesn't. Okay, doesn't. So once we discover the bias, we got this awareness for the student and the educator, then we go to the next three steps, sorry. Okay, and now what are we going to do is to, okay, we know now the bias, now we have to move the bias to another, into one direction. We have to diminish this or try to abolish, probably try to abolish is going to be really difficult, but at least to diminish how this bias is affecting their decisions. Okay, and once you know in which direction you have to move, you need to establish a strategy. Okay, and then once you get this strategy, you have to come back again to the probably this same case study or a similar one, and now try to see if the student could tackle this bias and being aware not to do in a way. Okay, you could also use here checklist, absolutely. Okay, something that you could always use, and also as many cases the student is doing, probably the better, so the experience is going to be good for them. Okay, but this little 3 steps, okay, really easy to do. Okay, this virtual software provides you the opportunity, some opportunities in order to help you usually in the first steps. Okay, so as a summary, I want you to remark that this dual system helps you a lot in order to understand how we make decisions and where the bias could be. Okay, the factors provoking those bias are really big. Okay, are really there are a lot of them. Okay, and some of them are related with your thoughts, your education. Okay, so they are not rare. They used to be probably all the clinicians we have them, and the only thing is to know exactly which of them in order to tackle. Again, here comes the software. You could use your experience, you could use your knowledge, and you could use this bias deviation in order to tackle them. Okay, and once you discover them, if you got a plan, and the only thing they have to do is to put it in action, and then comes to the cycle again. Okay, and that's all. Thank you very much for having me and for paying attention. If you need any other extra further question or whatever, I'm here to answer. Thank you very much.